you all here on yet another very special Global Morning Report, where we are lucky enough to host a group of dear friends and actually a very special program. This program is near and dear to our hearts, Ascension Providence, for many, many reasons. Primarily because our beloved Sukriti is actually there and is an intern there as we speak. And I really, really look forward to getting to know the folks in the program a little bit better today. And just to outline our agenda, we'll hang out, chat with our friends from Ascension Providence, and then jump into a case to kind of get to know their program through the lens of a patient experience. And then we'll actually open it up to everybody in the audience to say hello and to get to know Sukriti's beloved program a little bit more. And in the meantime, we'll learn a lot of medicine, get to know a lot of wonderful people, and just hang out for the next hour or so. So without further ado, we have two esteemed guests joining us. Lina, do you want to unmute yourself and introduce yourself to the VMR crew?
Sure, Robbie. So hi, everyone. I'm Lena Elnamer. I'm one of the third-year chiefs at Ascension Providence Hospital. I'm so excited to be here. I've been listening to Clinical Problem Solvers podcast since I was an intern. Actually, I think it was Dr. Heffernan and Dr. Hassan who introduced this podcast to me. And I do have long drives that I go to from Michigan to Pittsburgh, where my husband is. It's around a 4.5 hour drive, and I listen to a lot of podcasts on my way there. I've been at Ascension Providence for the past 3 years. That's when I moved to Michigan for my residency. I'm originally from Jordan, and I was born in Oregon, moved to the States back to the States for residency. During my spare time, I like to work out. I like to play tennis and body pump. That's my favorite workout. And I enjoy cooking and traveling.
Oh, that sounds absolutely amazing. It's such a delight to meet you, and thank you for tuning in to the podcast. It's always a treat to hear about people who've been listening in for quite a while, at least 2 years. How do you like living in Michigan?
I love living in Michigan. It's very nice, especially during the fall. The colors are just so beautiful. Yeah. And Michigan has been great. It's a bit colder than what I prefer, but it's really nice. I like the cultural diversity over there. That's one of my favorite things about Michigan, and I absolutely love it.
That sounds marvelous. So you've been many places. Sounds like you're born in Oregon and then you moved back to Jordan. Does that sound right? And then where did you land back in the US when you came back?
Actually, I was in Rochester, New York for a while. My husband was finishing his chief residency over there. Then I moved to Pittsburgh for around a year, and then I moved to Michigan. So yeah, I was all over the place for sure.
That sounds wonderful. And you were saying something that really struck with me, and I'll tell you why in a moment, but can you tell us more about were you referring to the diversity in Michigan?
For sure, yeah. So I think that stems from my class, my residency program, my hospital, and even the place where I live at. I noticed that there are different people from different parts of the world, and this is one of the things that I adore about Michigan. So for instance, I'm from Jordan. A lot of my friends are from the Middle East. Some of my other friends are from India, Pakistan, and just all over the world. So this is one of the things that I feel Michigan is so unique about.
Oh, that's so cool. Thank you for sharing that. At the very beginning, in the very first program we hosted for this event, Jacobi Medical Center in New York, I shared the sense that I like you feel like I'm in sort of the bridge between what it's like to be a US medical graduate, but also have tentacles in the IMG world. And I spent all my life before coming to the United States for college abroad in Lebanon and then Pakistan. But the reason my journey was a little bit easier is because I was born as a US citizen because my mom was in the United States in the 1970s, and she spent over 10 years here. And she spent all those 10 years in Michigan. There's a very large Arab community. She was in around the Ann Arbor area, actually. but moved around a lot and actually lived in a bunch of towns whose names I admit forget, and I'm grateful that she doesn't watch this now. Yeah, that's right. Actually, Ravi, she was in Dearborn.
Exactly. Dearborn, probably. I was gonna say that.
Yeah, you triggered that memory. So I think the Michigan's inherent diversity is a large part of why I get to sit here in San Francisco and hang out with you all. So I definitely will amplify and resonate that. I can't wait to introduce Dr. Heffernan in a moment, but I have to ask you, as the VMR crew knows, you have to tell us what your favorite delicacy is. So if you have your favorite meal planned later today, what would that favorite meal be?
Planned as in I'm cooking it or takeout?
You get to choose whatever you want.
All right. Probably my top favorite is hummus and falafel. I'm gonna do that. I miss that so bad, and I think Michigan has provided the closest to home for sure.
Yeah.
So hummus and falafel are probably my favorite.
Amazing. If anyone on this call doesn't know what Lina is referring to, please Google images it, and then you might have to leave to get your own because it's absolutely that delicious.
Yeah, hummus is like a chickpea blend. It's so good, and you dip it like you dip the falafel in the hummus. So that's one of my favorite meals for sure.
Amazing. We'll have to battle offline about where hummus originated from, because I think we each have competing.
True. I'll give you that. Definitely Lebanon, because they do make it better.
All right, I didn't expect to win that battle so easily. I thank you.
I've been to Beirut, and their hummus is just so good that I just go there again just to try it for sure.
Awesome. Well, Ahlan wa sahlan. Thank you for joining us. It's so nice to have you here.
Thank you.
And the other representative from the program is Dr. Jeremy Heffernan, who's here to say hello. Good morning.
Hello.
It's so nice to see you finally.
Yeah, thank you. So nice to see you all.
Do you want to tell us a little bit about yourself?
Absolutely. I know you guys are in for a great episode. With Lina and Sukriti, they make my job very easy. They're superstars in our program. So I'm the associate program director at Ascension Providence. A little bit about myself, I guess I'm actually Canadian. Born and raised in London, Ontario, Canada, which is right near Toronto. Did my schooling there, and then did my some clerkships in residency at Ascension Providence, and then stayed on as faculty afterwards, and now work as faculty and as the APD. We are academically, we kind of wear two hats in the program, Robbie. We really have very much a community feel. It's a mid-sized residency program. There's about 18 residency / fellowships within the two campuses. We are academically associated with Michigan State University College of Human Medicine. So my interests really lie, of course, in academics. That's why I stayed on as faculty. I love teaching. I love point of care ultrasound. That's something that I've been really kind of new for me, and really kind of a new passion for me. I do a lot of simulation within the program. And then, of course, I have a kind of a private practice, as well as probably 70% of my time is still spent in the hospital, rounding with residents. Yeah.
Oh, that sounds marvelous. I hadn't realized that you two are an IMG of sorts in many ways.
Yes. I still live in Canada. Actually, I commute across.
Oh yeah. Well, what's that commute like?
You know what? Because our Southfield campus, which I'm primarily at, is really just outside of Detroit, which borders with Windsor. Yeah. And Windsor is which is in Canada. So I live in. So it takes me about 30 minutes daily to commute. It's not too bad.
Amazing. So you commute nationally to work. That's fascinating to me. It
was logistically easier. I have a family and a wife and two kids, and so just with respect to visas and all of that stuff, it was much easier for us to stay here and for me to commute across.
Well, and what's the commute like is it a crossing the border as a daily venture? How is that? What is that experience like?
In pandemic world, it's been okay because the traffic has been really just essential workers. So that part has been really nice. Usually before that, it depends. Most of the time, because our hours as physicians are so early and sometimes so late, that I miss most of the rush hour traffic. So it's not too bad at all. It's doable.
That's
Yeah.
absolutely fascinating. Didn't even cross my mind. That is so, so cool. It looks like we have a friend from Canada too who's saying hello in the chat.
Oh, good.
Yeah, we're gonna jump into the case and get to know both of you better, but I also cannot help but I can't skip over the food theme of VMR. So do you want to tell us what your maybe I don't know, maybe we can take advantage of your being from Canada and tell us what your favorite Canadian dish is.
You know what, like so my favorite food is not what I'll tell you about. I mean, if I had to pick one thing today, I would probably go to a place and get takeout at a place called Georgia Ray's, which is basically Southern style chicken. It's
Ooh.
incredible. And recently, and we got Chick-fil-A here in Windsor for the first time.
Nice.
And I know that's nothing new for Americans and people living in the US and things like this, but just, you know, it opened 2 weekends ago, and the average wait time when it's open has been almost 2 hours for a chicken sandwich. So I haven't tried it yet, but I will. But I think the one thing that most people, when they come to Canada, they want to think about, and if the Canadians are listening, is probably poutine, which I don't know if anybody has heard it. Poutine is really a conglomeration of French fries and cheese curds that are melted, and then you melt it with like a type of a hot gravy, and then you can add whatever your, you know, preference is, whether it be, you know, a lot of time people put chicken, or I mean, I've even seen lobster poutine, and you can add obviously vegetables to it. So it's not the healthiest, of course, but it's fantastic.
That sounds absolutely delicious. I learned of poutine only through my VMR adventures, and actually, ironically enough, it was Kushal who taught me about poutine a long time ago. Well, we hope to get to know you better and get to know your program better, and we'll transition to the case in a moment. But I can't help but introduce a lot of the CP Solvers crew who actually make this happen, and I will go around and introduce them real quick for the sake of time, and just in no random order in my screen. Now, you've heard a lot about Sukriti. She is originally from India and is now doing her residency at said program, and is clearly a celebrity at Ascension Providence. And then right under Sukriti on my screen is the one and only Rafa, who is always has his pensive look on right before we jump in. So Rafa is an esteemed colleague and friend from Brazil who's joining us. And next to him is Gabriel, who for the first time is fading his background, which I think is an absolute delight, because he's really led us into his life in many ways recently, and has been on the VMR religiously from basically day one, including when he's been on vacation. Hello, Gabriel. Good morning. Also above him, I have Danya, who's joining us from Pakistan and taking time away from her evenings with her family on Saturday to join us. And in his favorite color, pink, right above Lina, is Kirtan, who's joining us from India, who you will know is the vasculitis guru, but that's only a small part of his very rounded persona. And then mid-bite, the one and only Maria, who's joining us from Guatemala, who I think needs no introduction. And next to her is Tiago, who is an endocrinology legend from Brazil, also joining us. And whether he realizes or not, he'll also represent his wife, who is a neurology attending, applying for neurology residency this year. Her name is Gabby. And joining us for the very first time on the Inside Scoop is Brodo, who is going to be doing the teaching points. He's here. He's originally from India and is here in the United States in California, and hoping to land a program. Lucky enough to have him in internal medicine. Hello, everyone. Let's jump into the case, and we'll get to know each other better there. And then I'll actually pass the mic to Sukriti to, at the end of the case, to connect us with our wonderful colleagues from Ascension Providence. All right, Lina, the mic is yours, my friend.
All right, awesome. Thank you for the introduction. So I'm going to start with the case. Our case is about a 41-year-old African-American male who presented to our ER for generalized fatigue, fever, and jaundice of 1 week duration, and he was found to have abnormal liver tests.
Okay, all right. That is an absolutely fascinating start, and I will let the chat chime in with thoughts. But we basically are learning of a middle-aged man who's coming in with fatigue, and was found to have abnormal liver issues. And those liver issues seem to be liver tests and hyperbilirubinemia. I think one thing that really that I've been reflecting on is race, and how race influences our analysis from the get-go. And I think in light of the medical community's deeper and deeper reflection into how race impacts life in general and life within medicine, I think different people have come to different conclusions about how race influences the diagnostic journey. And I think within focusing just on the diagnostic journey, we're learning more and more that the way we've been using race within diagnosis is probably wrong. I still think there's a tremendous value to it, and I will share with you how, with Lena revealing that information, I changes my analysis. But it's one second. My dog has opinions about this conversation. He thinks this is really controversial. Why are you talking about it? And it's because the answer is very simple. Race, I think, historically has been used as a marker of genetics. And so all the step 1 and step 2 exams that Lynn and I took all painted sarcoidosis as an African-American predominant disease, and maybe the exams that you're still taking. But we learned that actually race is a very poor predictor of a genetic disease. In fact, there's a fascinating study that looked at genetic markers in a waiting room in a clinic, and found that there was more genetic diversity between Black patients in that same room compared to Black and white patients in that same room. So the link between genetics and skin color has been debunked. And so more and more we're having to question all this litany of data that we've used to study diagnosis, because we were learning more and more that skin color, not too surprisingly, is a very poor predictor of genetic background. So some people would say, well, that should mean that you shouldn't include race in part of your analysis. And I respect that opinion. And I think that it is actually still pretty helpful to use race in your analysis, because race, while it does not correlate with any genetic propensity for disease, including sickle cell, we should look about it. I think we tend to have that association. What about sickle cell? Even then. But I think it's important to include race because it is intimately linked with access to healthcare, socioeconomic status, and a variety of socio-cultural factors. So here you might have to think about what the implications are of this patient's race in regards to access to healthcare, access to medicines, nutritional status, and things of that nature. So it is, I think, a very powerful variable, and one that you should use to your advantage. And to use it to your advantage does not mean to link it to any genetic conditions. So here, that's the only piece of background that we have. And I think I would make sure that we're not assuming this person is otherwise healthy. We don't know that quite yet. And Lena has given us a really rich foreground to think about. And that rich foreground is saying, hey, there's something wrong with the liver. We're making that assumption because the liver enzymes are elevated and the patient is jaundiced. But you have to be careful, because there is one possibility that this scenario has nothing to do with the liver. And that possibility is that the jaundice is from indirect hyperbilirubinemia, and that the liver enzymes are an AST predominant liver enzyme elevation, simply reflecting the breakdown of red blood cells or hemolysis. So there's one possibility that we're completely astray here by analyzing the liver. But in all likelihood, because of the liver enzymes often reflecting liver disease and bilirubin often being direct, we're probably dealing with a liver problem. And my only caveat before I scan the chat is we tend to divide liver problems into the liver parenchyma and then the outflow tract, so otherwise referred to as intrahepatic liver disease or extrahepatic liver disease. And the key question will be, how can we predict where the lesion is? Is it in the liver itself, or is it in the biliary duct outside it? And that's where the height of the AST, ALT compared to the height of the OPFOS will be very, very helpful. But the key question now is this intrahepatic or extrahepatic? And more data will help us elucidate that. I'm just looking at the chat. Hans, I love that point. Can you elaborate on the point you were making about Scandinavia and Germany with regards to sarcoid?
Yes, and I was quite surprised. When my mom was diagnosed with sarcoidosis, which turned out to be something entirely different, I came to know a friend of mine who had sarcoidosis. He had flu-like symptoms over a long period of time, and he had even had some liver function tests which were not normal anymore. And it took about, at the clinic and the University of Tübingen, I think 6 weeks or even longer, to finally boil it down to sarcoidosis. And he had some lymph nodes taken out of his mediastinum. And then I got to know a lady from my hometown, and she had erythema nodosum and sarcoidosis as well. The sarcoidosis went away when she became pregnant, by the way.
What? Oh, I didn't know that. That's fast. I guess
I didn't know it either. All the medications were quite ineffective for her, but when she was pregnant, it was gone away.
Usually pregnancy is a wonderful thing, but it tends to add to the healthcare complications with a variety of them. I'm glad to hear that sometimes things can get better with pregnancy. That's marvelous.
Maybe because it causes a hypoimmune, a depressed immune system, and that could probably, I'm not sure, but that is a guess of mine.
Yeah, I think I'm definitely inclined to speculate similarly. Awesome. Lena, you've given us a lot of intrigue to jump into this case. Do you want to give us your next round of data?
Sure. Thank you for that breakdown and the mentioning of the race and medicine. I think that's a very important topic nowadays in the world of medicine. Okay, I'm going to move on to the HPI. So his illness began around 1 week ago, prior to presentation, with the onset of fever and fatigue, followed shortly by jaundice. He stated that he was at home when his symptoms started, and his highest temperature was 104 degrees Fahrenheit. He took Tylenol and Motrin, which sort of controlled the fever, but he decided to go to the urgent care to get tested for COVID-19, but that was negative. So his fever was back in a couple of days, and he decided to go to the urgent care again to get tested, and that was negative as well. He denied any recent travel. He denied any eating out or takeout. He did notice that his urine is becoming darker with time. His stool color is becoming lighter, and he described it as clay colored. Since his fever was not resolving and he got more concerned, he decided to present to our ER for further evaluation. All right, I'm going to move on to the pertinent review of systems. He did have jaundice, fever, fatigue that we mentioned. In addition, he had nausea and loss of appetite, which led to 7 pounds of unintentional weight loss within the past week. The dark urine and acolic stools that I mentioned. Apart from that, he denied any itching of the skin. He didn't have any abdominal pain. He didn't have any change in bowel habit, including diarrhea or constipation or vomiting. And he did not have a skin rash. He denied any other urinary symptoms, no neurological symptoms, no cardiovascular or respiratory symptoms. Moving on, he does have a past medical history of discoid lupus. The past surgical history and family history were non-contributory for the scope of this presentation. He denied smoking, he denied drinking alcohol, and the travel that I mentioned within the past 2 years, he also denied that. He is sexually active in a monogamous relationship with his wife. Regarding his medications, he is on hydroxychloroquine 200 milligrams twice a day for the past 2 years. There were no recent changes to his medication or to the dosage, and he denied any over-the-counter medications or herbal supplements. Moving on to his vitals and physical examination, and Robbie, let me know if you want me to stop at any point. I know that the information is a lot at this time. His temperature was 100.1 degrees Fahrenheit. His blood pressure was 125/80. His heart rate was 79. His respiratory rate was 14, and his oxygen saturation was 100% on room air. He was alert and oriented to time, person, and place. He did not appear in any distress, but the jaundice was noticed by scleral icterus bilaterally. He didn't have any cervical adenopathy. Regarding his neurological and musculoskeletal exam, that was unremarkable. And for his cardiovascular and respiratory exam, that was unremarkable as well. For his abdominal exam, I want to mention that he did not have any hepatosplenomegaly or right upper quadrant abdominal tenderness or any tenderness in any other region. For his skin examination, he didn't have any lesions or rashes that were visualized. All right, so I'm looking at the PowerPoint. I think we got everything on there. I'm gonna move on to the labs.
Maybe because I think the labs will help us really understand this case. I think it's a great point to pause for a few minutes and reflect on what we can predict with the labs, because it's not a secret that the labs kind of give it away in terms of at least beginning to know what we're dealing with. And I think your astute history taking and exam have taken us a long way. And the reason, just for everybody listening, the reason I think it's very helpful for you to start to understand what a program may look like is through how a case is told and unfold. And many of you have been on VMR many times before and have seen how a story is told, and you're seeing how Lina has a masterful understanding of the details of this case. What she's doing by telling us that the patient has clay-colored stools is she's essentially telling us that the bilirubin is direct. Indirect hyperbilirubinemia does not result in clay-colored stools, nor does it result in dark urine. And the reason that is that clay-colored stools signify a lack of bilirubin making it into the stool in the first place. And that bilirubin is exclusively the products of direct bilirubinemia. Indirect bilirubin is also insoluble in water, poorly soluble, so it doesn't leak into the urine. So the combination of clay-colored stools and dark urine is very suggestive of direct hyperbilirubinemia, and it takes the astute historian like Lina to uncover that piece of history. What is further supportive of now that direct bilirubin almost confirms that it's liver disease, so I think we can predict that to a high degree of certainty. The question is, well, what kind of liver disease? And fundamentally, there's two kinds. There's acute and chronic. And chronic liver disease, otherwise known as cirrhosis, has a very unique signature on exam. In addition to jaundice, patients tend to have markers of high estrogen exposure, such as gynecomastia and palmoerythema. They also tend to have ascites and splenomegaly. And her pointing out those pertinent negatives, she was subtly saying, hey, no rashes. Hey, the spleen is normal. This is an excellent presenter telling you that this patient does not have liver disease. So I would take a lot from how Lina is telling us the story. So I think we can say that this is an acute febrile liver disease. And the assumption there is that you have to be careful and assume that well, let me rephrase. We know this patient is going to have some form of hepatic involvement, but that doesn't leave them immune to having, in addition to having hepatic involvement, non-hepatic involvement. So for example, could this patient have sickle cell anemia causing indirect hyperbilirubinemia and then have a liver complication of sickle cell, such as sickle cell hepatopathy? So we know the liver is involved, and the question is there something else going on? And the something else going on will be gleaned from the labs with how much indirect hyperbilirubinemia the patient has, but also from the background history that Lina has given us. So the two pieces of background history that are most informative are the discoid lupus and the patient being originally from the continent of Africa. So how does the discoid lupus help us? There's actually three kinds of lupus. There's systemic lupus erythematosus, there's subacute cutaneous lupus erythematosus, and then there is chronic cutaneous, otherwise known as discoid. If you map them out in that order, acute, subacute, and chronic, that correlates with the degree of visceral involvement and the degree of cutaneous compromise. The more acute disease, the more likely you are to have systemic symptoms. The more chronic disease, the more likely you are to have scars and cutaneous problems with less visceral complications. So discoid lupus is a scarring form of lupus that tends to affect the scalp and the face and has about a 20 to 30% risk of visceral involvement. in stark contrast to acute cutaneous lupus erythematosus, which almost universally has visceral involvement. And subacute cutaneous lupus, which is often drug-induced, actually lives between those two probabilities. So here, the person has lupus. They're at risk for visceral complications, but they would be much higher if he had had acute cutaneous disease. And the patient being from Africa has two dimensions to it. One is you wonder about access to care, about vaccination status, and then infectious organisms that may reactivate. And we assume that there's a long latency period, so we'll have to invoke infections with a long latency period like granulomatous infections, and rarely, depending on where the patient is from, a Vivax or Ovale, a malaria Vivax or Ovale. So the short version of this reflection is to commend you on your terrific presentation to tell us essentially that this patient has direct hyperbilirubinemia and has no evidence of chronic liver disease. And I will add discoid lupus. There's a risk of systemic disease, but it's not 100%. And the patient being from Africa may open the doors to esoteric infections, the query of vaccination status, and the possibility of long-standing latent infections. There's so much wisdom in the chat. I encourage you to check it all out. There's a lot of pearls flowing in there about cancers and diagnoses we featured on VMR, like benign recurrent intrahepatic cholestasis. So check it out. In the meantime, I'll go back to Lina to give us more data.
Thank you so much, Robbie. That was a great approach. I also want to mention that by listening to the podcasts, my thought process in medicine kind of changed, and the way that I approach the problems, I'm putting them into categories, and I tried to teach that schema to my interns as well. And I think that is very important. And I also want to, just a small advice for the students and residents listening, to not shy away if you forget anything that you forgot to ask the patient. It's okay to go back and mention that and put that question in if several times. You're not going to master it from day one. And I've been there where I forgot to ask a specific question, and I went back to the call room and I realized that. So I went back in and I asked that question. Moving on to the labs, for the CBC, the white count was 3.44, and that is normal differential, and that is not changed from his baseline. The hemoglobin is 12.8, the platelets are 117, and the hematocrit is 36.6. Just to mention that this is unchanged from his baseline 3 months ago. For his CMP, for his electrolytes, his sodium was 138, his potassium was 3.8, chloride of 106, BUN of 6, and a creatinine of 1, and a glucose of 106. And I want to move on to the liver tests, my favorite. AST is 619, ALT is 658, total bilirubin is 4, direct bilirubin is 3.1, alkaline phosphatase is 284, total protein is 6.2, albumin is 3.3, INR panel showed a PT of 12.5, INR of 1.0, and a PTT of 30.7. So with initial abnormal liver enzymes, and having said that the patient did have normal tests 3 months ago, we proceeded with an approach to acutely abnormal liver enzymes. Hepatitis A IgM was negative. Hepatitis B surface antigen and hepatitis B core antibody were negative. Hepatitis C virus RNA and antibody were negative. EBV and CMV titers were negative. HSV titer was negative. HIV screening after obtaining a consent from the patient was negative. He did mention that he took Tylenol and Motrin for the fever. We did not know how much. It was hard for him to quantify, so we obtained an acetaminophen level that was 5.9, which is low, a salicylate level that was undetected, less than 3. Moving on. We proceeded with other testing. So anti-smooth muscle antibody was negative. Anti-double-stranded DNA was negative. And I saw that someone mentioned in the chat an antibody that is specific for lupus hepatitis. We obtained that, which is anti-ribosomal P antibody that was negative. The IgG level was greater than 2000, which was high. And he did have a positive ANA in 1 to 80 titer in a speckled pattern. Moving on, we did obtain some imaging. I see that someone's asking about the alkaline phosphatase. I can go back. It was around 284. All right. So another thing that we wanted to rule out was ischemia. Right upper quadrant ultrasound with Doppler showed patent hepatic vasculature, otherwise unremarkable, and MRCP showed no evidence of biliary obstruction. Testing for Wilson disease, alpha-1 antitrypsin deficiency, and hemochromatosis were all negative. And at this point, the thought process was either, should I move on or do you want me to pause? Okay, the thought process was either autoimmune hepatitis or drug-induced liver injury from the hydroxychloroquine 200 milligrams twice daily that he has been taking. So because the diagnosis was not clear, we proceeded with a liver biopsy. The liver biopsy showed several findings, including portal fibrosis, lobular plasma cells, and inflamed portal tracts with eosinophils, plasma cells, and neutrophils. And those changes are suggestive actually of either autoimmune hepatitis or DILI, or drug-induced liver injury. So after expert consultation and transfer to a liver transplant hospital, hydroxychloroquine was discontinued. It was considered a culprit. And the patient was actually started on prednisone 60 milligram once daily, and eventually azathioprine 50 milligrams once daily for lupus though. The liver chemistries were back to normal within 8 weeks. And after consulting the hepatologist, they think, the hepatology team, they think it's more of drug-induced liver injury just because of the abrupt onset and the fever. So the liver enzymes on week 8 showed a total bilirubin of 0.6, an alkaline phosphatase of 68, an AST of 32, and an ALT of 23.
Wow, what a marvelous journey that you took us on. I think that workup was just absolutely outstanding, and the narration of it too, the same. I think you reminded us, the first, I think you localized the lesion with your imaging, because we were saying, is it intrahepatic or post-hepatic? And I think with your MRCP and right upper quadrant ultrasound, we didn't see anything anywhere. And so by exclusion, this is an intrahepatic disease process, which is either infection, drugs, and then rare possibilities like autoimmune hepatitis. And congenital diseases like Wilson's disease. And you ruled all of them out, ultimately needing a liver biopsy. And I think this is not an uncommon tension. Is it autoimmune hepatitis or drug-induced disease, both of which are tricky to tease out? I recently learned of the possibility of drug-induced autoimmune hepatitis, which can occur with a variety of antibiotics. And I would have to read about whether plaquenil has been associated with that. But I think that journey was absolutely marvelous. And I'm so glad the patient is doing very well. I'll hand the mic back to you, Lena, to teach us what you learned from this case and what you took away from it.
So yeah, that's what I thought about hydroxychloroquine too. One of the things that I learned from this case is the availability of a national database by the NIH and Drug-Induced Liver Injury Network, which is LiverTox. I wasn't aware of that available database, and you can go on LiverTox and search over 1,000 drugs that are on there and check what kind of hepatotoxicity a medication can cause, even some herbal supplements. So by Googling hydroxychloroquine today, it was not really associated with a lot of cases for hepatotoxicity, except 2 cases that were reported on there. One was a case series for 2 cases that caused acute liver failure. And the other was a newer case that caused acute liver failure as well. But those were after initiation of the drug within a couple of weeks. Our patient's case was different. He has been on the medication for so long that we kind of drifted away from DILI in this case. But another thing that I learned is to keep a very broad differential when tackling such a clinical problem, and to keep everything in mind, including the zebras and the more common things approached with such a problem. Another thing that I wanted to touch upon, and I think you mentioned that, is the importance of obtaining a thorough history. And one thing that I learned is the term HILI, which is herbal-induced liver injury. And sometimes when we tend to ask patients, what medications do you take? They think of prescribed medication, but it's also important for us to trigger their thought process by asking them, what over-the-counter medications do you take? What herbal supplements do you use? Did you purchase anything online that you have been taking for sleep, for instance? And I've been noticing this to be more common nowadays.
I don't know why I'm in my chair and you're in yours. I feel like I need to present a case to you for you to teach us. That was absolutely amazing. You should consider that. Because I'm inclined to ask, does your future involve studying the liver closely, or maybe not so much?
Yes, I'm applying for GI right now, and I would like to do hepatology later on.
Well, I will tell you, I think you should start doing hepatology right now. I don't know why there has to be a delay. That was absolutely amazing. Thank you so much. It's such a good case and so much learning along the way. As the esteemed attending on the case, Jeremy, I don't know if you have any wisdom or thoughts to add before we move away from the case part and get to know you all in the program better.
You know what, when I was going through it, there's 2 things I really realized is Robbie and in the CP team. I don't know how you guys can listen with all the activity going on the screen. It's quite impressive. I have the attention span of a hummingbird, and I'm looking at it back and forth. I'm like, I don't know how you do it. So I'm super impressed. But no, I don't have a lot to add. I think Lina has definitely showcased that the student has definitely become the teacher, and not surprising. She's been making this transition probably since intern year very, very effectively. So no, she's amazing and did a great job, better than I could do, no doubt about it.
Very, very kind of you. I'll tell you that I didn't know Sukriti was scribing, so she was the only person who can even come close to matching Lina's presentation brilliance. Is Sukriti, who was actually keeping up with her the whole time on the whiteboard. It's really, really impressive to see. Sukriti, before I hand the mic to you for you to since you have a foot in both worlds, CP solvers and the program, to guide the conversation. I didn't realize. Oh, thank you, Maria, for pointing out that Danya was involved too. I'm sorry for that oversight. Brodo, we'd love. Wait, where? Sorry. Oh, where am I? Oh, yeah, right here. Sorry about that. Before I hand the mic to you, Sukriti, maybe we can have Brody summarize our teaching points of the case, because I imagine going back to them will be a little bit hard once we dive deeper into the program. So, welcome, Brody, for your first time doing CP Solvers teaching points on VMR. He's been a very valued member of the community, and excited to hear your recap of the case today, Brody.
Thank you, Robbie. I think I've tried as much as I could to synthesize this information, and under headings such as race and medicine, I felt that I liked your point about linked preferably to social determinants of health rather than genetic propensity to disease states. And then I think we opened up with jaundice and liver problems, could be in the parenchyma or in the outflow tract, subset biliary tract, to be teased about either with history or investigations. The clues in the history would be something like the stool color and the urine colors. A clay colored stool and high colored urine would point towards indirect hyperbilirubinemia more. Sorry, hold on. I think that's direct. And investigations, the liver enzymes provide the biggest clues, like the balance between the transaminases and the alk phos and GGTs. And then lupus and hepatitis, didn't actually have much clue about this, but I learned a lot. Acute, subacute, and cutaneous lupus, and in that order for systemic involvement. Discoid lupus is mostly the chronic cutaneous form of lupus, which has scarring involved. And loved Kirtan's point about SLE with anti-ribosomal phosphate. I think that has a link with in lupus with hepatitis, with or without the other antibodies. Was trying to get some points from the viral hepatitis part, which is in the chat, but I'm still working on that. And drug-induced hepatitis is high transaminasemia, and drug-induced liver injury can have protein manifestations ranging from acute liver failure, subacute to chronic. And I absolutely love the point about herbal-induced liver injury, something I have seen a lot in India, and it's something that should be considered ruling out in history. So those are what I tried to put in.
So good, so good. I love the headings too. They really help punctuate parts of the case. Thank you so much. All right, Sukriti, the mic's all yours.
Hey everyone, that was really awesome. Lina's really one of the, one of the brilliant residents in our program, and it was really awesome to learn from her. So maybe we'll just open up the floor to any questions from anybody in the audience, and I think we'll be happy to answer any.
Thank you, Sukriti. I think Sukriti is one of the brilliant interns that we've had the pleasure working with so far. And I'm so happy that she actually introduced this opportunity for us to be here today with everyone and present this case.
I have to say too, I have not had the guts to, last year I was like, I organized grand rounds for our hospital system, and I kept wanting to get CP solvers to do it, and I kept just deferring it. And then until Sukriti joined our program, and then when I mentioned to her this year, she kind of helped materialize this whole thing. I still want to get you guys for grand rounds eventually. But yeah, I really want to say thank you to Sukriti as well for allowing us to be here. It's honestly a true honor to be part of this. You guys are definitely changing things. The CP solvers, I think internal medicine as a program now, or as a residency program, is being viewed in a different light in many ways because of you guys. So I really tip my hat to the work you guys are doing. It's amazing.
So I think while we kind of wait for more questions to come in, maybe I thought I could ask Lina a question. I don't think I've had the opportunity to ask you, Lina, but I guess what's your favorite memory from your 3 years?
Oh, my favorite memory. I think I would say, I think I have a lot of good memories, but one that crosses my mind right now is when the pandemic started, I couldn't travel back to Jordan, and I was missing my family and my home so much that even like I went to just to go there and see them, and it's been over 2 years since the start of my residency. We started doing COVID teams at that time, and I remember that one of my friends, he's from Iraq, and his mom made us a famous popular Iraqi dish called dolma, which is grape leaves stuffed with rice, and she actually brought us lunch to the hospital. She cooked it at home, and at that moment I felt like I was at home, away from home. It meant like a lot to me, and I knew that I was at the perfect environment, surrounded by great people.
That was really nice. Thanks, Lina, for sharing. I think Jasimran has a question. If you'd like to unmute.
Yeah, sure. I messaged in the chat. Hello, everyone. So my question is regarding, like, if I want to look for our options after residency, while going towards primary care, hospitalist, or into any subspecialty. So will there be any specific mentorship or personalized guidance regarding our future pathways? That's all.
Oh, I'm not sure, Lina or Dr. Heffernan, if one of you'd like to answer.
I mean, I can take this one, Linda, if you'd like. With respect to, for our residents in the program or medical students coming in, I think mentorship is definitely a big part of our program. We introduce it pretty early, usually within the first week during orientation, and it's kind of followed throughout. And that's usually, I look at it in two different ways. There's a direct kind of mentee to mentor, which is resident to faculty. And then there's obviously a lot of mentoring that goes on within the residency program itself within the residents. And it's not always just resident to chief resident. I think that happens throughout all of your years. And I think what's really conducive to that is not only the individuals within the program, but also I think the size of the program is very conducive to that. So in terms of helping you gauge what you want to do afterwards, I think a lot of that education comes from your interactions with your colleagues, and then with the subspecialists you get to meet, and faculty, internal medicine faculty you get to meet. And when you have a mid-sized program, this is what I love about it. And this is, to be honest with you, why I stayed on, was I got to know everybody really well when I was a resident there. You get to know, and I was always thinking about critical care, and then life got in the way, and family and kids and stuff, but you get to know those individuals very well within this program because of the size. I think we foster that environment. So you get to know the fellows very well. You get to know a lot of the subspecialty attendings, and I think they provide a lot of comfort within your journey to figure out your career. I think that's honestly, and I don't know if Lina agrees, now that she is literally right on the step of a fellowship, I am 100% confident that Lina will be a GI fellow somewhere. I'm going to touch wood, but I'm very confident in that. But I don't know if Lina, you want to comment on that as well.
Thank you, Dr. Heffernan. Yeah, I agree. I think by the availability of fellowship in our program and the availability of mentorship within our internal medicine program as well, and the chances to do electives, you get the blend to work with different fellows, different subspecialists, and your mentor, which I found probably was the most useful, that my own mentor did guide me. She did tell me who to go to if I'm interested in this certain field, who to talk to from her past experience, where her residents, when they graduated, how were they able to go into the career that they wanted. So I think the combination of those three do play a role in career options later on, for sure.
Thank you.
Does anybody have questions? Or I'd always love to steal the opportunity to ask Lina and Dr. Heffernan something.
For sure.
Sorry, Ravi.
No, I was just going to reflect on, I think people are just in awe of the last 40 minutes of what Lina just did, sitting back there and absorbing. So I'll moderate the chat while you ask your question.
I guess, Lina, I think this is super important now that we're all on the virtual world and we're getting to know programs, and it's a little different, but I'd love to know what sort of why you chose this program, or why you really like this program.
Actually, Sukriti, it's good that you bring that point. I'm a kind of person where when I did my interviews, not in the virtual world, I liked what I saw when I went to that hospital. I liked the vibes of the environment, and that kind of played an important role in me choosing where to go to. But now, unfortunately, in the virtual world, things are different, and I'm sure that hospitals and programs are trying to make them as close to in real life as much as possible. So one of the things that attracted me to Ascension Providence was, again, the collegial environment. I can't emphasize on that enough, especially for an international medical graduate whose family is abroad and overseas. I think that is very important to be around people that make you feel like family and make you feel at home. So that's one of the major things that attracted me for sure.
Yeah, I'd love to add on that. Just a quick point, but I think there was a recent interview when somebody asked me the same question, and I said that it's really hard to feel out of place at this program because everybody comes from such diverse backgrounds, and I think it really speaks to the leadership in terms of everyone's, you know, their diverse interests. Some people have taken a more traditional versus some others a non-traditional route to medicine. So it's such a melting pot of culture that I think that's one of my favorite things too. And I see Dr. Singh in the chat has asked, what fun group activities do residents do outside of your program?
Actually, I was going to mention to Sukriti that when I'm on outpatient, especially during the third year, I kind of miss being in the lounge, in the resident lounge. I miss seeing all of you guys. And I kind of have like a FOMO or just missing being there. So that's one of the things. One of the things that we like to do, especially the third years, is tea time during the day. We gather around. We do have more time than the others, so we do have like a cooler in our resident lounge where we have different types of teas. Hopefully, none of them cause any hilly, and we make our own tea time. And that's one of the 30 that I absolutely adored. Like those 30 minutes are so valuable to us. Outside of work, some of the residents in my class, we like to play tennis together in a sports park that is close to where we live. We've been to a lot of cider mills in Michigan. It's known for its apple orchards, I guess, and that's one of the activities that we like to do during the fall. And I know that our program, along with the Palm Crit program, they like to play soccer together. So it's residents, and I think they have nurses too who go and play with them, and they really enjoy their time.
We used to have amazing, when I was a resident there, we used to have amazing battles, both on the basketball court and the volleyball court against some of the DMC orthopedic residents and things like this. I don't know if that still happens, but we used to do that back in the day. But yes, soccer's always been a major staple for as long as I can remember. And I didn't know about the tea time, which is actually pretty cool. You know, I'm not going to say anything about, you know, work being done during that valuable period of time. But I think the third years usually deserve that by the time when they get to that point.
We're trying to engage. So it's kind of a motivation, actually. Whenever the work is done, they can join us.
Well, I can't believe you all mentioned tea and soccer in the same paragraph. I'm finishing my tea now, and I think folks, especially Ravi, actually know how much soccer is near and dear to my heart. So I hope the CP Solvers has the privilege of joining you for grand rounds in person someday in the, I know, distant future, but with the pandemic the way it is now. And if we ever have that privilege, I would love I'd love to play soccer with you all and have a cup of tea afterward.
Which tea are you having?
You know, unfortunately, I should be more picky with my tea. Right now, I'm just having very simple green tea. I had too much caffeine this morning, so yeah, I go light. I'm surrounded by tea connoisseurs, especially very, very close and upfront. So I usually don't get to decide, don't have the knowledge to decide the quality of tea, but I have access to like a range of teas that are all very, very good. And yes, I would love to come visit Portugal and watch FC Porto play. Although as a Cristiano Ronaldo fan, I'm supposed to say no, I don't like Porto, but not really.
Another MUFC fan here.
Yes.
So happy he's back.
I know, right? I won't talk about today, but yes, because we lost to Man City. But yes, very, very happy he's back.
Ravi, do we have time for another question?
Yeah, you know, Mohammed has asked, I think this is Mohammed's first question that I've scene. So how could we not honor it and have him unmute and ask his questions? But maybe it can be our final question for today.
Hi, my name is Mohammed. I'm calling from England. I'm just asking about POCUS and the simulation sessions and how often they're available.
Do you want me to do that, answer that question, Sukriti?
Yeah, Dr. Heffernan,
Yeah, okay. Okay, yes, hi. So point of care ultrasound is, I think we've been doing it for about, you mean 2 years. And so what does that mean we're doing it? Well, we've, you know, a lot of our faculty have an interest in it, and to create a curriculum within a residency program, it takes a lot. So we're kind of in those, I guess, infancy stages of it, where we've, you know, we have the equipment, we have the resources. So quite a few of our faculty are trained or going through training, and we're really using point of care ultrasound as a tool for education at this point. So for bedside rounds and for ambulatory procedures and things like this, it's still very new. I imagine in the next 10 years, point of care ultrasound will be probably in the pocket of most, either definitely faculty and most residents, I imagine, as the technology evolves and the cost per unit goes down. It is pretty amazing technology to do. So we try to use it as much as we can. And I think as our faculty continues to get trained, we'll use it more and more. I'm actually doing the advanced course coming up in Chicago this year, which will be kind of cool. Our simulation center is amazing. It's state of the art. We've had it now for as long as I can remember, 6-7 years. And it's not just internal medicine that uses it. Pretty much every residency and fellowship use it. And so it's got pretty much everything you can do. From an internal medicine standpoint, we do a lot of simulation ACLS, so mock code blues. We have quite a few scenarios that we run residents through. We usually do 1 session per week with different cohorts of residents. With respect to other things in simulation, we do a lot of simulated central line, arterial line, interosseous access, what other LPs, of course, and those types of things. So we also use it for different types of patient encounters. So to get, you know, gyneco training, those types of things as well. So simulation is a big part of our program, and most of the time our residents are in the sim lab during their +1 week. We use the 4+1 model, and they're usually there 1 morning every 5 weeks, and then plus their mock code sessions. I don't know if that answered your question.
No, thank you so much. That's a great answer. Thank you.
You're very welcome.
Awesome. Well, I think the chat is focused on ultrasound, but also Manchester United, which is very telling given the day. But I just want to thank you both, Lina and Jeremy, for joining us today, and thanks to Sukriti for making this possible. It really wouldn't at all been without your help. I hope you learned a lot about livers, and but more importantly, you learned a lot from our wonderful guests who shed light into their own personal lives, their program, and how they take care of their patients. It's always a delight to hang out with you all on Saturday, and I hope you enjoyed today just as much as I did. I'm going to have a refill on my green tea and a very quiet Saturday, and I hope you all have a wonderful rest of your day, and hope to see you tomorrow for student VMR, and then literally every day as we nerd out together. Alrighty, y'all. Thank you. Have a wonderful day.
Thank you so much.
Thank you.
Thank you, everyone.